everybody, Dr. Beth Zog here. I slimmed down my thermography presentation to just this section on the history of measuring skin temperature. And I think it's pretty exciting to see that looking at the heat that radiates off of sick patients goes back long before chiropractic, and medical researchers are still looking at the use of thermography in research today. In this first slide, we look at what did D.D. Palmer think about skin temperature. And it would be interesting to see that D.D. discovered that the body is heated by nerves, not by blood. Now, really, it's both, isn't it? Because the nervous system controls blood flow. In the afternoon of July 1st, 1903, in the Aiken block of Santa Barbara, California, D.D. Palmer was holding a clinic. The patient was Roy Renwick of that city, and students present were H.D. Renard, Ira H. Lucas, O.G. Smith, Minora C. Paxson, A.B. Whitman, and M.A. Collier, in all 8 witnesses. The patient, Renwick, had his left hand, arm, and shoulder, and up to the spine, intensely hot. Dr. Palmer drew the attention to the class to the excessive heat condition of the portion named, the balance being normal in temperature. He then gave an adjustment in the dorsal region, which relieved a pinched nerve on the left side, also the excess heat of the left upper limb. And this is from a Scrapbook Autobiography of Chiropractic by Todd Waters. If we go back much farther to 1700 BC, we find that Egyptian medical texts included measurements of thermal variations in 6 out of 47 case studies. In 350 BC, Aristotle considered the warmth of the body to emanate from the heart. In 400 BC, ancient Greek physicians placed wet mud on the bodies of sick people to locate diseased areas. Isn't that amazing? Hippocrates is quoted as saying, should one part of the body be colder or hotter than the other, disease is present in that part. And then in the 2nd century, Heron of Alexandria developed a special bulb called a thermoscope. Now, I actually compiled all of these dates and examples from many different places. So this is the most thorough listing of kind of papers or articles written about measuring skin temperature that I could find, but I'm sure there are many more that I haven't located yet. And if you know of different ones, please send them to me and I'll add that to the presentation. Galileo converted the thermoscope into a crude thermometer as far back as 1592. And then it was Sanctorius that improved the thermometer in 1659. In the 1700s, the Fahrenheit thermometer and a specific reference point were determined, which was 32 degrees, melting point of ice, 96 degrees, standard temperature of humans. In 1800, Sir William Herschel, who was King George III's royal astronomer, discovered dark heat, which was later called infrared. So this is important when we're looking at our infrared instruments, such as the DTG or the Titron. Since sometime after this discovery, then he developed the very first thermogram. In 1829, this is an important date for chiropractic, the thermocouple principle as a method of measuring heat differentials was discovered by T.J. Seebeck. So your thermocouple instruments are going to be your nervous scope, your NCM, and basically these instruments were not developed to determine the exact temperature, but rather to compare the heat on the right side of the body compared to the left side of the body. 1835 was the beginning of modern thermography, and that's when it was established that 98.6 degrees Fahrenheit and 37 degrees Celsius are healthy human temperatures. Today we know that there's an acceptable range of human temperature between 98 to 99 degrees Fahrenheit. Remember that our bodies have to continually adapt to internal and external forces or stresses, And so you're not going to expect the temperature of any human to be exactly 98.6 at all times. So that's where we go more to this range of 98 to 99. In 1852, vasomotor control mechanisms of thermoregulation were discovered. In 1857, Spurgeon and Sequin attempted surface thermography, and in 1817, Albert introduced the self-regulatory mercury thermometer. And for those of you that are a little older like me, you remember the old-time mercury thermometers. No fun at all. It was in 1898 that D.D. Palmer detected hot boxes. Now remember, chiropractic was started in 1895, so this was very early into the development of the science of chiropractic. Just for reference, I included that it was 1910 that the Merrick system and the spinograph were introduced to the profession. In the 1920s, recording of the infrared spectrum in photography was used, and then this very important date of August 24, 1924, BJ introduced the NCM, the neurocoulometer, at Palmer College Lyceum, which was like homecoming. The NCM used the thermocouples for paraspinal thermal analysis. One of my favorite books written by BJ was History in the Making, and that was written in 1957. So remember, BJ passed away in 1961, so this was just a few years before he passed away. BJ wrote, "The spinograph portrayed the visible concrete locations and positions of vertebral subluxations and misalignments." So BJ never considered anything below C2 to be a subluxation. So anything below that he would have called the misalignment. BJ said that the NCM produced evidence of the invisible two factors, the abstract pressures and interferences, resistance to normal flow of mental impulse supply, excess heat, etc. This did not necessarily disprove our hot box, taut and tender fibers, Merrick system, majors and minors, but it did prove where such were and were not, before and after adjustment or correction. So adjustment was for the subluxation, correction was for the misalignments. Whether it was an adjustment or just a push, shove, squeeze, or punch in the back, which did or did not release pressure and restore transmission of mental impulse supply. So here we see BJ utilizing instrumentation to determine was the adjustment given at the right place, at the right time, the right line of drive, the right amount of force, etc. Was NA able to take that force and correct the subluxation or not? Dr. Otto Schernbeck developed a graphing instrument that recorded the heat breaks. The heat breaks from one side to another, especially if repeatable, were considered to be evidence of a subluxation impingement. And Dr. Otto Schernbeck was one of the higher ups at the college in those last days when BJ was there. And so you'll see his name quite a bit in history papers. You can see in this picture an early NCM with the calligraph. And if you ever get the chance to visit Palmer College, then they do have some of these old instruments on display on campus. So I highly recommend, if you've never been to Davenport, Iowa, that you make the trip. B.J. Palmer developed the pattern system of analysis in 1930, and it was also in the 1930s that Hardy demonstrated that the skin is a near perfect emitter of infrared radiation, or what is called emissivity. In the 1940s, the nervoscope was developed and manufactured in New York. And it was in 1948 that the first known thermogram was taken by Dr. Leo Massapust of the vascular patterns in extremities and breasts. Dr. Clarence Gonstead developed the brake system of analysis in 1950. In 1956, Dr. Ray Lawson established the first known medical application for thermography with extensive research with breast patterns. Lawson discovered that skin temperature over cancer in the breast was higher than that of normal tissue. Now, maybe you've heard of Pierce technique or Pierce-Stillwagon technique. You may not realize that it was doctors Vern Pierce and Glenn Stillwagon that introduced the DTG, or the dermathermograph, in the 1960s. It had received its patent in 1967. And of course, this is especially interesting to us in the Thompson group, because Dr. Thompson was very, very close friends with Pierce and Stillwagon. As a matter of fact, the two of them studied the Thompson technique quite thoroughly in their development of the Pierce-Stillwagon work. In the picture to the left here, you see Dr. Thompson and his wife Peggy on the left, and then you see Dr. Vern Pierce and his wife on the right. And what you may not know is that when Pierce and Stillwagon produced the DTGs, one of their big contracts fell through at the last minute, and they needed a lot of money. And so Pierce asked my grandpa to invest in the production of the instruments. And when my grandpa talked to my grandma, she said, absolutely not. But my grandpa went ahead and gave their entire life savings to Pierce and Stillwagon because he believed so much in this DTG. Well, thankfully, Pierce was able to get a new contract, and my grandpa did get his money back, and that's a good thing, because I hate to think the hell that would have been paid if my grandpa would have lost all of my grandparents' life savings. But this just goes to show that chiropractors in those early years were willing to risk and give everything they had for the progress in the profession. In 1972, the Department of Health, Education, and Welfare declared thermography was beyond experimental in the evaluation of breast and vascular analysis, as well as extracranial evaluations and neuromuscular analysis. And then in 1973, Dudley published the first paper on thermography in the ACA journal. In 1974, liquid crystal thermography was developed for routine clinical use. Now, if you've ever seen pictures of liquid crystal thermography, it was really quite an extensive process. And it was interesting because when Stillwagon and Pierce were doing their research in thermography, they actually used liquid crystal in research. And what they did is they would put that black tarry stuff, over the patient's back to be able to take the thermograms. Well, they had to decide what technique to use, because obviously they really couldn't adjust into the spine where the liquid crystal was spread out. So what they decided to do was research with just a simple Logan basic contact. And I wish I still had the slides, but the changes that were made in thermography in a positive direction with just that Logan basic contact were outstanding. And so, these are some of the early things that were happening with Pierce Stillwagon work with thermography. And this is what really showed me the power of Logan basic technique, which I believe that should be taught in every college today. In 1979, Wexler published a protocol for the diagnostic use of spinal thermography, combining spinal and peripheral patterns. In other words, there was a protocol used to do a full spine on the back, obviously, of the patient, and then they would correlate the changes or asymmetries in that scan to the upper extremity for, say, the cervical region, or the lower extremity for the lower back patterns. And so they found that when you saw a consistent, asymmetry or change in, like, say, the cervical region and the upper extremity, or the lumbar region and the lower extremity, that greatly increased your chances of getting the right diagnosis. In 1982, Barbara Britt published a book outlining the scientific techniques and protocols for medical thermography. Thermography was used where abnormal variations of skin temperature might occur in female breasts, peripheral vascular disease, musculoskeletal disorders, extracranial vascular disease, thyroid gland abnormalities, and inflammatory conditions. In 1982, the Bureau of Medical Devices classified medical telethermography as a Category 2 device. And in 1984, that was the first showing of the Visitherm, and this was developed by Drs. Glenn and Kevin Stillwagon. Now, this was an amazing instrument. At the end of this presentation, I'll show you some of the scans. And man, this, of all the instruments I've ever had, this really was my favorite, and you'll see why when we get to that part. In 1984, also, clinical thermography was approved by the California Board as a part of the chiropractic scope of practice. And then in 1985, Titronics developed in the very first infrared scanner with barrels for tight collimation and a distance measuring wheel. The data was transformed to the computer over a 12-conductor cable, and the software was all black and white, displaying the line graphs and also a bar graph of the temperature profile of an outline of a person's back. So this is really interesting because up to this point, like let's take the DTG for example, you would have to take like a little piece of elastic and put dots on it and stretch that elastic out along the patient's back. Then you would kind of wherever the dots were on your elastic, you would put a mark on the patient's back. Because the scanner, once you pulled the trigger, had little beeps. And so you would try to get to the next dot on the patient's back by the time that you heard the next beep, so that you could get a consistent reading. Well, as you can imagine, this was kind of time consuming. You know, not every patient wanted to have a marker on their back, and it wasn't perfectly repeatable. Well, what Titron did is that they created a system where it measured by distance instead of time, which is a much better idea. And so whether the patient maybe had on higher waist pants or lower waist pants, that distance can adapt to that because it goes based off of where you end the scan at the top. And so this really, I think, was a brilliant idea that Titronics had, and a much improved method of being able to provide consistent, reliable scans. By 1987, there were articles about thermography in all of the leading journals and periodicals. And then in 1993, Titronics developed the pistol grip in their C3000. 1996 was the first generation of the thermal scanner introduced as part of the Millennium Subluxation Station, and the third generation of the Neurothermal came out in 2013. Now, the subluxation station was awesome. I remember when this came out and everybody wanted one because it would provide multiple methods of objective measures. Pictured on the left is Roger Titone of Titronics, and if you have never met Roger, you're missing out. He is the most brilliant, kind, and sweet and wonderful man ever. He's right here in Iowa near me in Tiffin, Iowa. So if, again, when you make your trip to Iowa to visit Palmer, then you can make your way to Tiffin, Iowa to visit Roger at Titronics. In 2009, thermal imaging was used in the assessment of the local physiological responses before and after conservative therapies. And in 2010, thermography was used to evaluate the feasibility of determining the extent of sympathetic blockade by skin temperature measurement with infrared thermography related to cranial extent of the temperature increased to that of the sensory block. So from here on out, I'm going to show you studies through time that showed that thermography was used to evaluate and research medical conditions or health conditions. In 2012, infrared thermography had been successfully used in diagnosis of breast cancer, diabetes neuropathy, peripheral vascular disorders. It was used to detect problems associated with gynecology, kidney transplantation, dermatology, hearing, neonatal physiology, fever screening, and brain imaging. 2013, thermography used to be good measuring test in determining block success when sensory testing is impossible. In other words, they would give the patients a nerve block and then do the thermography to see like it did in fact that block work. In this study, thermography was used to confirm the hypothesis that blocking the sciatic nerve would lead to an increase in temperature and correlate with existing sensory block tests. In 2015, thermography was used to assess temperature changes during dental extractions to evaluate its correlation to heart rate changes as a marker of pain and discomfort. 2017, thermography was used to test the hypothesis that individuals with focal onset epilepsy have colder abdominal areas, suggesting the need for more research on abdominal injury, inflammation, and adhesions in the epileptic pathology. 2018 suggested that the use of thermography in physiology classes could help students visualize and learn complex physiological concepts that are challenging in the traditional theoretical course format. This would allow students and professors to discuss concepts from other disciplines such as physics, biophysics, and image processing, facilitating translation of knowledge from the classroom to daily life applications. 2018, National Healthcare Systems recognized thermography as a diagnostic test for complex regional pain syndrome. This typically develops after an injury, stroke, surgery, or heart attack, where pain is out of proportion to the severity of the initial injury. Now, why am I showing you all these studies? Well, I'm showing you these studies because I want you to understand that while many in our profession poo-poo the use of thermography or say there's no science linking skin temperature to the nervous system, well, chiropractors say that. The medical profession is using thermography as a valid tool in studying other things. And I just cannot believe that we are the only profession that doesn't really value this great tool, which is still very inexpensive and something that every chiropractor could use in their daily practice. In 2018, I found a couple studies. The first saying that thermography was measured to show changes in blood flow at the mandibular angle and Horner syndrome in a rate model of superior cervical ganglion block. Also used to study metabolic and vascular activity. A broad number of diseases affect skin temperature, such as arthritis, repetitive strain injuries, muscle pain, and circulatory problems. In 2019, the American Academy of Thermology suggested that sympathetic skin response studies, such as cold stress infrared imaging, provide a valuable diagnostic tool for this study of the complex regional pain syndromes, reflex sympathetic dystrophy, thoracic outlet syndrome, vasomotor headache, and other, arterial insufficiencies and vasospasmatic diseases. And this was also done in veterinary medicine. So can we look at these medical studies and can they show us kind of proof that a subluxation exists without even realizing that they're supporting chiropractic? And why does the chiropractic profession dismiss thermography while medical researchers are using it as a trusted tool in their research? Now look at this study. Cardiovascular and temperature changes in spinal cord injured rats at rest and during autonomic dysreflexia. In the blue, I just gave you the definition of autonomic dysreflexia, also known as hyperreflexia. This is a condition in which your involuntary nervous system overreacts to external or bodily stimuli. So in this study, by comparing the observations of cardiovascular and temperature responses following a spinal cord injury, the study has presented for the first time the extent of autonomic dysfunction that occurs following full spinal cord transection, as well as the relationship between two parameters. Cardiovascular and thermal dysfunction in the rat after the spinal cord injury can provide a useful model for understanding autonomic changes in spinal patients, although the time course of development is faster in rats. Recording the dynamic changes in surface temperature of spinal patients, such as through monitoring of skin temperature in the toe, might allow the detection of episodes of autonomic dysreflexia before they manifest as severe symptoms such as a headache. The early detection of autonomic dysreflexia during the pre-symptomatic stage could aid in the care of spinal patients by allowing earlier elimination of the triggering stimuli, thus preventing the need for vasoactive drugs. Now, while these researchers are looking at this as a way to prescribe medications, don't we know as chiropractors that we will oftentimes see asymmetry in thermal scans long before the patient has any symptoms? And aren't we always telling our patients that they need to get in and get checked even if they don't have symptoms, because nobody can really tell if they have a subluxation. You could have a subluxation and have no pain, no muscle spasm, but you still have that impact of the subluxation on the nervous system, specifically here the autonomic nervous system or the sympathetic nervous system, that is showing a change in skin temperature. This is another interesting article. September 2020 is looking at infrared thermography as a technique to measure physiological stress in birds. They found that changes in surface temperature following exposure to an acute stressor are thought to be promising indicators of the physiological stress response that may be captured non-invasively by infrared thermography. In some species, the bill of the beak temperature may serve as a more robust indicator of autonomic stress responsiveness than the eye region. So these researchers are using skin temperature to evaluate the body's response to stress. Does that sound like something that we could be using as a part of our criteria in evaluating our patient's progress? So these are what a picture from a camera system would look like. And here we see that we're looking at the arms and the forearms. And so we know that thermal symmetry is normal. So basically everything on the right should look similar to everything on the left. And the goal is to have that normal range be within 0.5 degrees Celsius from right side to left side. And then again, just showing you what a lower extremity study would look like with the camera system. So I wanted to show you some scans from the Visitherm that we talked about earlier. And these scans were taken in the 1990s. And so this was a really cool instrument that was developed by Drs. Kevin and Glenn Stowagen, as we mentioned, where this scanner had like a paddle that had numerous infrared sensors across it, and you would just kind of run that whole paddle up the entire back, and then it would turn it into a thermogram. And typically when we do our scans, we try to do 3 pre-scans and then 3 post-scans. And so normal with the picture, like the weather map picture of the back, would look kind of like a tadpole shape where there were no hot or cold spots on the right side or the left side, but then there were also no hot or cold bands across the spine. So on the bottom then, what they did is they would take like a DTG reading, which was just measuring the actual temperature on the spine, on the right-hand side of the spine, let's say. And so any swing to the right would indicate heat, and any swing to the left would indicate cold. And so then they would take the graph on the left-hand side, and so what you see on the bottom is an overlapping of a DTG scan on the right and a direct temperature scan on the left. They overlap those. So now we can see any kind of splits between the 2 lines. I don't know if you can see with my pointer, but here we have the 2 lines. They're not overlapping. So that would show you asymmetry from the right side to the left side. Now the nice thing about that, about the direct temperature, is that you can see where those hot and cold bands are. So this was a really genius instrument. Now I think it's pretty exciting because Titronics has added this feature for those of us old timers who really liked, kind of the system of overlapping the right side and left side DTG graph. They've added that feature to their online program, so I think that's pretty awesome. So we know that any big shifts, like any hot or cold bands in the spine that are greater than 1 degree Celsius, are significant. And then any asymmetries between the right side of the spine and the left side of the spine are significant. So if you look kind of down here at these three graphs on the right, you see that bright red over like the base of the sacrum. That's increased heat, so we don't want to see that. And then look at the line graphs on the bottom. You see how both sides of the DTG, both graphs, start far to the right. And so that's where you can start to look at line graphs and actually visualize what a color picture thermogram would look like. When we're looking at a pre and a post scan on a thermogram, what we're wanting to see is not a perfect scan after the adjustment. I mean, sometimes that will happen, and that's awesome when it does, but really what we're looking for is just a change on the post scan that is moving us more toward thermal symmetry and starting to eliminate those hot and cold segmental bands. So in this Visitherm scan, you can see like the scan on the right with the two, yellow scans, where the line graphs are pretty much perfectly overlapping with no deflections to the right or to the left and no major asymmetries. That would be a very nice post scan. So if we bring this to more modern instrumentation, this is a Titron scan, and this is one of my patients, and this is a really pretty good scan here. We can see that the line on the right-hand side, this is what the DTG scan would look like along the right-hand side of the patient's spine. If you go to the far left, this is what the DTG scan would look on the left-hand side of the patient. Then the middle line is the differential between these two. So this is what your NCM or nervous scope graph would look like. And I really like this little printout that comes with like a kind of a report you can give to the patient that comes with the Titron program. So this is an example of a pre and a post for the Titron scan. If you look at the middle graph, that's the delta T graph, you can see that the pre-graph was outside of a normal range. So the normal range would be 1/2 degree Celsius, which is from one line to the next is 1/2 degree Celsius. So on the pre, you can see that in some areas we were, 1.5 degrees out of a normal range for asymmetry. Look down here again in the lumbar region, another 1.5, almost 2, a whole full degree. And then on the post, we see the green where everything is kind of staying within that normal range, staying within 1/2 degree Celsius. And then for the segmental part of it, we can see how there was a kind of a big shift here on really both sides, going from colder to warmer, and especially here at this like kind of T1 area. We see this is pretty common in chronic patients, where there's a big, cold shift at that T1 area, which on the post scan we see that moving back toward normal. Now, what I've found is that it's easier, much easier to bring thermal symmetry back to the patient through care, but it does sometimes take a long time to eliminate these cold bands. So just be patient. As long as you're moving in the right direction, then you're doing the right thing. So looking at this pre and post scan, the pre scan is the black, where do you see the asymmetry in that middle line graph? Well, of course, we see some asymmetry here, okay, about 1.5 degrees, so 0.5. And then up here again, we see more than a 1/2 degree asymmetry, just a little bit out of range. And then on the post graph, we see everything comes back in line between these two lines, staying within that normal range. And then this is another pre and a post. Now these are not the same visit. This of course took a lot of time for this patient to finally get within a normal range. But look, when we started off, she was 0.5, 1, almost 1.5 degrees asymmetry, which was really bad. I show you this graph because I want you to see how there's a difference in these line lengths. This is what I was talking about with the way that Titron, the instrument measures by distance, not by time. So here, the patient must have had on like higher underwear, higher pants or something. We started up a little bit higher, but the program was able to adapt for that. So we still got, really consistent, accurate readings. So I really, really like this instrument. Personally, I think this is the best instrument on the market right now. I think if you had like a setup where you had a camera system, you could use maybe every 12 visits or something like that, and then in between use this instrument. That would give you a ton of great information. Now these next scans have nothing to do with thermography history, but I just want to show them to you because I find them extremely both interesting and a little bit terrifying. So these were patients that I had for many years, and these were scans that I took after they received their COVID vaccination, okay? And I just want to show these to you because I think it's really curious how they all show similar changes in the same region of the spine. So kind of consistently, I found a massive change, asymmetry, in this upper lumbar, kind of lower thoracic, upper lumbar region in so many of these patients. I mean, look at the asymmetry in this patient. This is off the charts. I've never seen scans like this. In all the years of practice, I've never seen anything that was this dramatic from people that had never had scans this far off. This was a massive cold spot on the left side of the spine. You can see that represented here. And it took several months for these patients' scans to get back to a normal range. Different patient, obviously not as significant as the other, but do you see how they have this, like, not only asymmetry, but these patients are showing a huge segmental differences. Like here you can see on both sides of the spine, increased heat in the lumbar and then cold through that like upper lumbar, lower thoracic region. And you're going to see through the rest of these pictures I show you, like this seemed to be kind of a common pattern. So here's another one, increased heat and then segmentally cold. And all those changes are happening at about that same level. Another one, extreme heat in the lumbars and then extreme cold in the thoracic. Again, these are all different people, all scans taken after their vaccinations. Pretty freaky. Let me know what you think about this. Here's another one, similar pattern. And another one. And then here's the last one I'll share. So I'm curious, what are your thoughts? I mean, what do you think this means? What part of the body do you think is being impacted that they're all showing the similar change in that kind of sympathetic area, that lower thoracic, upper lumbar region? So research that was done at Canadian Memorial, and this would have been years and years ago, found that the most effective places to adjust according to thermography were C1 and sacrum, which I think is pretty interesting because we go back to, the Palmer HIO work, and then of course that Logan Basic work. They found that adjusting into cold spots seemed to irritate the nervous system, And they found that bilateral cold areas seemed to indicate a sacrum adjustment was needed. So, and they also found that, I think this is interesting, that one adjustment worked best. So in other words, sometimes we do more for our patient by adjusting just 1 or 2 levels than, trying to rack and crack the entire spine. So I'll just leave you with this quote by Dr. Glenn Stillwagon. He said, "If we do not use an instrument and we adjust our patients every time they come in, we take chiropractic science and art and turn it into a therapy. Adjust only when it's needed and monitor with an instrument." I hope that you found this history of thermography and a few little extra tidbits interesting. Please reach out to me with any questions. I've got my phone number here. This is my cell and also my office number. And then the best email is just thebethzogdc@gmail.com. So I appreciate you all. I hope that you have a great day.